welcome to the Deep Dive. Today we're tackling autoimmune hepatitis, AIH for short. Think of it as your body's immune system, well, kind of getting its wires crossed and deciding your liver needs attacking. We've got your revision notes right here.
Yeah.
And our mission really is to boil them down into the absolute essentials, the stuff that'll stick, giving you a solid grasp of AIH.
Absolutely.
So whether you're facing exams or just want to understand these liver conditions better, let's dive in.
Sounds good. And what's really interesting about AIH, I think, is how a problem with the immune system can zone in, specifically on the liver.
Right.
So we'll be breaking down exactly what it is, what might set it off, who's more likely to get it, and really crucially, how we manage it.
Yeah.
So let's kick off with the fundamental question. What actually defines autoimmune hepatitis?
Okay, right. So at its core, AIH is a long-term inflammatory thing happening in the liver. Chronic, meaning it sticks around, and inflammatory points to the damage being done. But the key bit is immune-mediated. Your own defense system is the one mistakenly targeting healthy liver cells.
Exactly. Like friendly fire.
Yeah, like your security team accidentally attacking its own base.
Precisely. And this misguided attack leads to a pretty classic set of findings. In blood tests, we often see raised liver enzymes. Those are, transaminases leaking out of damaged liver cells.
Okay.
And high levels of immunoglobulin G, or IgG, that's a type of antibody. And if you actually look at a liver biopsy under the microscope, you'd see clear signs of inflammation.
And then there's that whole bunch of autoantibodies that can pop up. It's like the immune system is sending out all these different distress signals.
Yeah, kind of.
What are the main ones we should try and remember?
Good question. So the key autoantibodies linked with AIH are the anti-nuclear antibody, ANA.
Okay.
Anti-smooth muscle antibody, ASA. Anti-liver kidney microsomal 1 antibody, that's anti-LKM1.
LKM1, right?
And antibodies against soluble liver antigen, anti-SLA. You might also hear about antimitochondrial antibody, AMA, and antiphospholipid antibodies, though there may be less specific sometimes. A sort of tip might be to focus on the liver-specific ones, like LKM and SLA, to help them stand out, maybe.
Okay, so these antibodies are like flags, helping us identify AIH. And are there different types of AIH based on which flags are flying?
Yes, exactly. AIH isn't just one single thing. We tend to classify it into types based on the main autoantibody we find. So type 1 is the most common. You see it in adults and kids, and it's usually linked to ASMA or ANA.
Yeah.
Type 2 is seen more often in children and is associated with anti-LKM1 or maybe anti-LC1 antibodies.
Okay, kids mainly for type 2.
Yeah. And then type 3, which is linked to that anti-SLA, tends to crop up more in middle-aged adults. So different antibody patterns can point towards slightly different presentations or groups.
It makes sense. Different immune targets might lead to some variation. What about when AIH kind of looks like it's affecting the bile ducts as well?
That's an important point. Sometimes AIH can have what we call cholestatic features.
Cholestatic?
Yeah, meaning it can sort of mimic other autoimmune liver diseases that primarily mess with the bile flow, like PBC or PSC. So the picture isn't always, completely clear-cut.
Right.
And we should probably also mention juvenile AIH quickly. This mainly affects young girls, and it's often quite aggressive, really active liver damage, super high liver enzymes, those high Ig levels we talked about, and a specific inflammation pattern on biopsy called interface hepatitis.
Interface hepatitis. Okay.
Yeah.
So juvenile AIH sounds like a particularly active form in that specific group.
Often, yes.
Okay, so that covers the what. Now, let's try and dig into the why. What do we actually know about what triggers AIH?
Well, this is where it gets a bit more complex, honestly. The exact cause or etiology isn't fully nailed down.
Right.
But the general thinking is it arises from a combination of someone's genetic makeup, how their immune system is functioning or maybe dysfunctioning, and certain environmental factors all sort of coming together. The fact we don't have one single cause really highlights that complex interplay between our genes and environment in, shaping immune responses. It's true for a lot of autoimmune conditions.
So it's not just one thing that sets it off then?
Exactly. There's likely a genetic predisposition. For some people are just born more susceptible because of the genes they inherited.
Okay.
Then there are the immunological factors, that core issue of the immune system misfiring and attacking the liver cells. And finally, we suspect environmental triggers play a role. These could be things like viral infections, maybe they somehow kickstart this abnormal immune response, or even certain drugs and toxins might provoke an immune attack, especially in someone who's already genetically susceptible.
It's interesting how something seemingly separate like a virus could potentially start such a, specific autoimmune response against the liver.
It is, yeah.
So who is more likely to develop AIH? What are the risk factors we should be aware of?
Well, several things seem to increase the risk. Having a family history of other autoimmune diseases, think lupus, rheumatoid arthritis, that sort of thing, can slightly bump up your risk for AIH.
Right. Suggests a shared tendency.
Exactly. A shared underlying sort of tendency for immune systems to go a bit haywire within families. Gender is a big one, too. AIH is much more common in women.
Okay.
We've already touched on the genetic part. And specific HLA haplotypes, you can think of these as specific versions of genes involved in immune recognition, like HLA-B8 and HLA-DR3 have been pretty consistently linked to increased susceptibility.
B8 and DR3, got it.
And finally, like we just mentioned, exposure to certain medications, chemicals, maybe toxins might act as those environmental triggers in some people.
And it seems AIH often brings friends, so to speak. I saw a pretty long list of associated conditions in the notes. Why is that?
That's right. It's actually quite common for people with AIH to have other autoimmune conditions at the same time. And this really underscores that idea of systemic immune dysregulation. When the immune system goes wrong, it doesn't always just affect one place.
Makes sense.
So we frequently see overlaps with autoimmune thyroid disorders, Graves', Hashimoto's, various blood disorders like anemias, low platelets, GI issues like Crohn's, ulcerative colitis, coeliac disease, kidney problems, respiratory conditions, even heart issues, endocrine stuff like type 1 diabetes, rheumatological conditions like rheumatoid arthritis or Sjogren's, skin conditions, even eye inflammation like uveitis. It's a really broad spectrum.
It really highlights how interconnected the immune system is, doesn't it?
It really does.
So we know the immune system is attacking the liver, but what's actually happening down at the cellular level? What's the pathophysiology?
Okay, so the core mechanism, the pathophysiology, involves this abnormal immune response targeting the liver cells themselves, the hepatocytes.
Right.
This leads to the production of those autoantibodies we discussed earlier, which probably contribute further to the ongoing inflammation and the destruction of liver tissue.
A vicious cycle.
Kind of, yeah. And if this process isn't stopped, it can unfortunately lead to liver fibrosis, that's scar tissue forming.
Scarring, okay.
And eventually cirrhosis, which is, severe irreversible liver damage. While we know this general sequence, the precise chain of immunological events that goes wrong, well, that's still being actively researched. We know genetics and environment likely set the stage.
Right, so a damaging cycle.
Yeah.
Immune attack, liver cell injury, and then the potential for long-term scarring. Now, when a doctor suspects AIH, what other conditions might be on their mind? What's the differential diagnosis look like?
Yes, the differential. That's a critical step because lots of liver diseases can present with similar symptoms. You really need to carefully consider and rule out other possibilities.
Makes sense.
Key things to think about include viral hepatitis, especially Hep B and C.
Right.
Liver damage from alcohol, obviously, and drug-induced liver injury is a big one, too. Then you've got other primary autoimmune liver diseases like primary biliary cholangitis, PBC, and primary sclerosing cholangitis, PSC, and also metabolic liver diseases. Getting the diagnosis right is absolutely crucial because the treatments can be very different.
Absolutely. You need to be sure you're treating the right underlying problem.
Right.
So how common is AIH? Let's talk epidemiology for a sec.
Okay. So in the UK, the estimated prevalence is around 1 in 100,000 people. And as we mentioned, it's more commonly diagnosed in women.
1 in 100,000.
Yeah. And while it can happen at any age, it's most often seen in young to middle-aged adults. Globally, looking at Europe, for instance, the estimate is a bit higher, maybe 10 to 17 cases per 100,000. The reality is AIH occurs worldwide, and we actually suspect the true numbers might be higher than reported.
Why is that?
Because it can sometimes have really subtle or just nonspecific symptoms, so it might go undiagnosed for a while.
Oh, okay.
But the general pattern holds, commonly affects young to middle-aged women, although, again, it can affect anyone, any age, any gender.
Okay, so not super rare, but not extremely common either, and definitely that tendency towards younger women. Now, what are the clues? What might make a doctor think of AIH in the first place? What are the typical clinical features?
Well, the way AIH presents can vary quite a lot, which, as you said, can make it tricky sometimes.
Right.
Some people might have zero symptoms, and it only gets picked up incidentally on routine blood tests.
Oh, wow.
Yeah. Others can have really noticeable, even severe symptoms. Common things include persistent fatigue, feeling really wiped out, jaundice, that yellowing of the skin and eyes. That happens in about half of patients.
50%, okay.
Discomfort or pain in the upper abdomen, and an enlarged liver hepatomegaly. Elevated liver enzymes on blood tests are another key flag, obviously. And sometimes symptoms that suggest more systemic inflammation, like joint pain, skin rashes, maybe a fever.
Yeah.
So it can be quite nonspecific initially.
Sounds like it could be a real diagnostic puzzle sometimes.
It definitely can be. Some patients might even present with what looks like a sudden acute hepatitis fever, more obvious jaundice, maybe feeling quite unwell.
Okay.
In women, amenorrhea, the absence of periods, can also be a clue sometimes.
Interesting.
And like we've said, finding those characteristic autoantibodies, ANA, SMA, LKM1 in the lab tests, along with those raised IgG levels, those are really important findings.
Right. The lab work is key.
Absolutely. And the liver biopsy is also a cornerstone. It often shows inflammation spreading beyond the normal boundaries of the liver structures. That's called piecemeal necrosis.
Piecemeal necrosis.
And another pattern called bridging necrosis, where the inflammation kind of connects different areas.
Oh, okay. Piecemeal, like nibbling at the edges, and bridging connecting areas. Those are helpful ways to picture the pathology.
Exactly. And it's worth remembering that spectrum of presentation.
Yeah.
It can be acute and severe, totally silent, or just kind of a long-term smoldering inflammation.
Right.
Sometimes there's a period where the disease is active but subclinical before any obvious symptoms appear. Other potential symptoms people might report include muscle aches, itching, sometimes quite intense itching.
Here it is, yeah.
Nausea, joint pains again, various skin rashes, maybe even increased facial hair in women, swelling in the legs, chest pain, unexplained weight loss.
It's a long list.
It is. And on physical exam, a doctor might find the enlarged liver or spleen, hepatomegaly or splenomegaly.
Okay.
Jaundice, those little spider angiomata on the skin, fluid in the abdomen ascites, or even signs of confusion, encephalopathy in more advanced cases.
That's a really broad range of potential signs and symptoms. Really highlights why a thorough workup is so vital when you suspect liver issues.
Definitely.
So once AIH is suspected, what are the key investigations we rely on to confirm it?
Right. So diagnosing ALH is really about piecing together a puzzle. You use biochemical tests, those immunological markers we talked about, and the histological findings from the liver biopsy. And crucially, you have to do all that while making sure you rule out other liver diseases. So key blood tests are fundamental. The liver function assessment, your LFTs, gives that initial picture, measuring enzyme levels. Testing for the autoantibodies, ANA, ASMA, LKM, etc., is crucial.
Yeah.
Serum protein electrophoresis and quantitative immunoglobulins, those can show that characteristic pattern of high IgG levels, usually polyclonal.
Polyclonal hypergammaglobulinemia.
That's the one. We look closely at the aminotransferases, AST and ALT. They're typically up, but how high they are doesn't always perfectly match how much liver damage there is.
Okay.
If they stay high during treatment, that suggests ongoing inflammation. Our goal is to get them back to normal.
Makes sense.
Serum alkaline phosphatase, the ALP, is usually normal or maybe just slightly raised. If it's significantly high, you should really think about other diagnoses, especially things affecting the bile ducts.
Right. Points away from classic AIH.
Yeah. And then low albumin levels or a prolonged prothrombin time, those can indicate more severe liver dysfunction. The liver isn't making proteins properly. A full blood count, the FBC, and a blood film might show things like mild low white cells anemia, sometimes a specific type called Coombs positive hemolytic anemia, low platelets, or maybe increased eosinophils. Lots to look for.
So a huge amount of info from the blood tests.
Yeah.
What about imaging? Does that help diagnose AIH?
Well, imaging like ultrasound or MRI isn't usually definitive for diagnosing AIH itself. It can't see the autoimmune process, but it can suggest inflammation or necrosis or even cirrhosis. If the liver looks irregular and nodular on the scan, that strongly suggests cirrhosis is already there.
Okay.
And importantly, imaging is vital for ruling out other things, gallstones, tumors, blockages, that sort of stuff.
But the liver biopsy is still the real MVP for confirming it, isn't it?
Absolutely. The liver biopsy is really the single most important diagnostic procedure. It's usually recommended pretty early on if AIH is suspected, even if it looks like acute hepatitis at first.
Why so early?
Because getting that tissue sample allows direct examination. You see the characteristic inflammation patterns we talk about, piecemeal and bridging necrosis, interface hepatitis.
Okay.
It also helps gauge the severity, how much inflammation, is there fibrosis, is there already cirrhosis. This gives really important prognostic information too.
Prognostic.
Yeah, it tells us about the likely course. Sadly, cirrhosis is already present in up to a third of patients by the time they're diagnosed.
A third. Wow.
Yeah, and those who have cirrhosis or that bridging necrosis pattern on biopsy tend to have a tougher initial outlook.
Okay, so a really thorough approach.
Yeah.
Bloods for markers and function, imaging to rule out other stuff, and the crucial liver biopsy to confirm and stage the damage. Once AIH is diagnosed, how do we manage it?
Okay, management. The main strategy is immunosuppressive therapy. The whole goal is to calm down that overactive immune system and stop it attacking the liver.
Right. Suppress the attack.
Exactly. This usually starts with a course of corticosteroids like prednisolone to get the inflammation down quickly. That's induction therapy.
Prednisolone first.
Yep. Then for longer-term control, to maintain remission, other immunosuppressants are typically used. Azathioprine is very common, or sometimes mycophenolate mofetil.
Azathioprine or mycophenolate for maintenance.
Correct. And regular monitoring is absolutely key, checking liver function tests, those autoantibody levels, to make sure the treatment's working and to adjust doses if needed.
So it's all about suppressing the immune system.
Wow.
What are the specific goals you're aiming for with treatment?
The main aim is what we call biochemical remission. That basically means getting those liver enzyme levels, the AST and ALT, and the IgG levels back down into the normal range.
Normal numbers, okay.
Corticosteroids, like prednisolone, are usually the first-line drugs to induce that remission. Then azathioprine is a very effective medication for maintaining remission in most patients long-term.
And if those don't work?
If the standard treatments aren't cutting it or cause too many side effects, then other immunosuppressants can be considered. There are other options.
Okay. And what about really severe cases? You mentioned liver damage progressing. What about transplantation?
Yeah, liver transplantation is definitely an option for patients who develop severe liver failure or acute liver failure, or in cases where the disease just doesn't respond well enough to the medical treatments.
Right.
Fortunately, with the improvements in immunosuppressive drugs over the years, the actual need for transplantation specifically for AIH has gone down.
That's good news.
It is, but it's important to know that AIH can sometimes come back, it can recur, even after a liver transplant.
Oh, really? Even in the new liver?
Yes, unfortunately, the underlying immune issue might still be there.
And ongoing monitoring sounds absolutely critical for anyone on these treatments.
It really is. For instance, before starting immunosuppression, we should check immunity to hepatitis A and B and vaccinate if needed, because catching those could be bad news on immunosuppressants.
Good point.
Regular blood tests are essential, checking liver function, blood sugar levels, steroids can affect that, and the full blood count, azathioprine, can affect bone marrow. Okay. And because long-term steroids can weaken bones, we usually recommend calcium and vitamin D supplements. We might do DXA scans to check bone density, especially before starting steroids, and then periodically.
Bone health, right?
And eyes, too. Long-term prednisolone increases the risk of glaucoma and cataracts, so regular eye checks are recommended, usually after about a year of treatment. It's a whole package of care, really.
It sounds like a very involved long-term strategy is definitely needed. So what can patients generally expect in the long run? What's the prognosis like for AIH?
Well, with consistent treatment and, importantly, good adherence, actually taking the medications as prescribed, the prognosis for AIH is generally pretty favorable these days.
That's encouraging.
It is. But it's a condition that really requires lifelong management. Untreated AIH, on the other hand, can be very serious. Without treatment, there's a significant mortality risk, maybe 50% within around 5 years.
Wow.
Due to progressive liver damage, cirrhosis, liver failure, and potentially needing a transplant.
So treatment is crucial.
Absolutely. The good news is that patients who get treated and stick with it typically have a positive long-term outlook, although, individual outcomes can vary. Staying on maintenance therapy, often azathioprine, maybe with or without a low dose of prednisolone, significantly cuts down the risk of the disease flaring up again, relapsing.
Okay.
But it is worth remembering that even with treatment, cirrhosis can still develop over time in a fair number of patients, perhaps up to 50% in some studies.
So early diagnosis and really sticking with that treatment plan are key for a good long-term outcome.
Definitely.
What sort of complications can come up either from AIH itself or maybe from the treatments?
Right, complications. Well, developing cirrhosis is a major one, and cirrhosis itself can then lead to further problems like liver failure, portal hypertension, that's high pressure in the liver's blood vessels,
Okay.
which can cause things like varices, swollen veins in the esophagus that can bleed. There's also an increased risk of developing liver cancer, hepatocellular carcinoma, or HCC, particularly in people who have cirrhosis.
Right, cancer risk with cirrhosis.
Yes. And, of course, the immunosuppressive drugs themselves can have side effects that need careful monitoring and management. In really advanced liver disease, you can see complications like ascites, that fluid buildup in the belly, hepatic encephalopathy, the confusion from liver dysfunction, and variceal bleeding, as I mentioned.
Okay.
There's also a rare thing called hyperviscosity syndrome that can happen if the IgG levels get extremely high, making the blood thick. And just to re-emphasize the cancer risk, for those patients who do develop cirrhosis from AIH, regular surveillance for HCC is vital, usually means an ultrasound scan and an alpha-fetoprotein blood test every 6 months.
Got it. Regular screening for cancer if cirrhosis develops.
Essential.
Okay. So it's clearly a serious condition with potentially serious outcomes if it's not managed well, but with the right treatment and careful monitoring, the outlook is much more positive.
That sums it up well.
So just to wrap up this deep dive on autoimmune hepatitis, let's quickly recap the absolute essentials for our listeners, especially if you're using this for MSRA revision. We've defined AIH, chronic autoimmune attack on the liver. We talked about the likely cause being a mix of genetics, immune factors, and environment. We covered key risk factors, family history, female gender, and those HLA types, remember, B8 and DR3.
Yep, B8, DR3.
We explained the pathophysiology, misdirected immune response causing inflammation, potentially leading to fibrosis and cirrhosis.
Right. Immune attack, inflammation, scarring.
We listed important differentials, viral hepatitis, PBC, drug injury, etc.
Crucial to rule those out.
Touched on epidemiology.
Yeah.
Prevalence around 1 in 100,000 in the UK, often young to middle-aged women.
But can affect anyone.
Detailed the variable clinical features, fatigue, jaundice, but can be asymptomatic or acute. Key labs, raised transaminases, raised IgG, and those key autoantibodies, ANA, ASMA, LKM, SLA.
Don't forget the IgG.
Definitely not. Went through investigations, blood tests galore, imaging for exclusion, and the crucial liver biopsy for confirmation and staging.
Biopsy is key.
Explained management. Immunosuppression, mainly corticosteroids like prednisolone for induction, azathioprine or MMF for maintenance, and lots of monitoring.
Lifelong management, usually.
And discussed prognosis. Generally good with treatment, but untreated is serious. Complications include cirrhosis, liver failure, HCC risk, and treatment side effects.
That covers the main points, I think. Understanding these core aspects of AIH is really essential for anyone in medicine. It's one of those conditions that needs, high degree of suspicion, careful investigation, and that long-term tailored management plan.
Absolutely. And for those of you looking for even more resources to help you absolutely smash your MSRA and just generally boost your medical knowledge, don't forget to check out PasttheMSRA.com.
Great resource.
And also freemsra.com. They're both packed with really valuable tools and info to support your learning.
Definitely worth a look.
Thanks, everyone, for joining us for this deep dive. We really hope it's given you a clear and memorable overview of autoimmune hepatitis. Now, here's a thought to maybe mull over. Given how complex autoimmune diseases are and the sort of broad brush approach of current immunosuppression with its side effects, what advancements do you think we might see in the future? Could we get more targeted, maybe more personalized treatments for conditions like AIH?
That's the million-dollar question, isn't it? It's certainly a really exciting area of ongoing research.
Definitely something to think about.
Yeah.
Okay, until our next deep dive.